All right, good morning, everybody. How we doing? Again? Thank you. Welcome, good morning, and I'm thrilled to see on day 2 of the public session, or day 3 for the state folks, or technically day 4 for the people on the NAMD board. It's been a long couple of days. It's been a long conference. It's been a fantastic conference, an extremely well-attended conference, an extremely informative, insightful, and hopefully educational and entertaining conference. And on the last day, which is Election Day, we still have, looks like, pretty close to 1,000 people here, which is fantastic, which means that the appetite to learn about Medicaid and the opportunity to kind of think about the future of Medicaid and the healthcare system is still relevant and interesting and a priority for all of you. So I am personally very, very pleased and very, very happy about that. So again, thank you all for being here. I'm gonna not take up too much time here and really kind of tee up the next session, which I'm really excited about. And just as a preface, similar to the session that we kicked off with yesterday with Sam Quinones and the discussion about Dreamland, the next session was kind of part of the brainchild of our board president, Tom Betlach of Arizona, who's always pushing us to sort of do something a little bit different, do something a little bit more provocative, something a little bit more thoughtful and interesting, and not just, a panel of people talking about an issue. And so he said, we should, let's engage with thought leaders and let's think about the future. And so I really started thinking, it's like, well, who might that be? And the name and the person who I kept kind of circling back around to is Dr. Ian Morrison, who is a noted author and futurist and prognosticator of all things healthcare. And when I've been kind of like talking with him on and off for a number of months about trying to find the right opportunity to do this, and fortunately he was able to be here on Election Day. This is not going to be the future of what happens on the election. This is not the kind of crystal ball we're going to be doing today, but we are really going to be looking out to the near and somewhat distant future of a lot of very important healthcare issues. So he's going to come up here. He has a number of slides he's going to talk through, and I remember I was talking to actually the plenary speaker at the upcoming lunch today, Vicki Wacchino, and I was kind of telling her what the agenda was going to look like, and I said, yeah, we're going to start the morning off with with a healthcare futurist, Dr. Ian Morrison. She said, oh, he's fantastic. We just had Andy Slavitt had him come over and talk to all of us, and it was wonderful. So I was like, oh, this is great. This is going to be wonderful. So I'm super excited about this. So what we're going to have is Dr. Morrison's going to come up here and prognosticate a little bit about the future of healthcare. And then what we're going to do is turn to 2 reactors to be able to listen to what he said, take it all in, and then either agree, disagree, but ground what he has been saying about the future with the reality in state Medicaid programs today. So our 2 reactors are going to be Justin Senior, Medicaid director in Florida, and I guess the interim HHS or health secretary in Florida, and then Judy Moore Peterson, who is the Medicaid director in Hawaii, and prior to that was the Medicaid director in Oregon. They are both long-serving Medicaid directors. They are both long-serving members of the NAMD board. They bring a wealth and a breadth of experiences, not just blue state and red state, not just East Coast and West Coast and Pacific Coast, but also a debate about who's got the best beaches and who's got the warmest state and who's got the best state to move to. But the two of them will take turns reacting to what we've seen, and then we're going to kind of moderate a little bit of a back and forth amongst the three of them to really kind of take some of these things forward. So I'm really excited about this, and so I am going to get off the stage and out of your way and turn the microphone over to Ian Morrison to say welcome and thanks for coming.
Thank you. Thank you very much. Thank you, Matt. What a pleasure and honor to be here on a momentous day. I'm a professional futurist. Some people, well, let me just first of all say my definition of a futurist is an economist who couldn't handle the calculus, basically. I'm in the sweeping generalization business, and a lot of people ask me, how exactly do you become a futurist? My undergraduate major at Edinburgh University in Scotland was Geographic and Economic Change in Scotland 1580 to 1830, which is incredibly useful. But it is a useful training. I've been a student of structural change in society now for 40 years, and I left Scotland in the late 70s, moved to Canada, and they let me in partly because I had an urban planning degree, but they didn't need urban planners in Vancouver, where I moved to. They needed them in the Yukon, and I was not going to the Yukon. And I ended up getting a job with Management Engineering Unit 13.1, which was the Canadian healthcare equivalent of the KGB. Spent 7 years in an academic medical center doing clinical re-engineering before it was called that. And working on my doctorate and in health policy and health economics. And then I got offered a job to join the Institute for the Future, the modestly entitled Institute for the Future in Menlo Park, California, to work on a project called Looking Ahead at American Healthcare that the Robert Wood Johnson Foundation sponsored. And I've basically been doing that ever since. I've been looking ahead at American healthcare. At the Institute for many years. I ran the health program there. I was CEO in the 90s. But for most of the last 20 years, I've been what I would describe as a free-floating radical. I come in for a day, insult people, and leave. It's a bit like Newt Gingrich, only at a lower price point. But anyway. So I want to talk, and I don't consider myself a deep expert on Medicaid. I work mostly with the private sector players, whether it be provider systems or health plans. But it is an honor to be here. But I care a lot about Medicaid. I was on the board of the California Healthcare Foundation for a decade. Obviously, we were very interested in that. I currently serve on the board of the Martin Luther King Hospital in Los Angeles, and Medicaid is like the gold card for us at MLK. And I sit on the Long Range Planning Committee at the Stanford Children's Hospital. So I do care a lot about Medicaid, but I don't consider myself a deep expert. Let me just share with you the basic rules for futurists. You should always make forecasts about things that are far off so that people can't tell whether you're right or wrong. Make so many forecasts, one of them has to be right. Never give people a number and a year in the same sentence. That's a very important one. And whatever you do, don't talk about elections the day of an election. It's a kind of stupid thing to do. So I'm going to violate that by talking about the election. But I do want to sort of give you a sense of what I think is going on in the field in healthcare more generally. I think we're making progress, and I'm actually more excited now than I've ever been in my 30 years in the US. And I will close by giving you as an outsider, kind of the takeaways, I guess, for Medicaid, and then we'll hear from our distinguished colleagues. So elections matter, right? I've had a partnership with the Harris Poll and the Harvard School of Public Health for 30 years, and Bob Blendon at Harvard always tells us that elections matter. And by the end of the day, which is, by the way, is the most overused phrase by pundits on CNN, at the end of the day, well, at the end of this day, we'll actually know the answer as to whether it's a blowout for Hillary Clinton or whether it's Brexit. And Brexit is particularly poignant for me as a Scot because you'll recall that the Scots voted overwhelmingly to remain in the European Union as did the Londoners, and it was the rest of Britain, particularly England, that voted against it. I'll remind you that Donald Trump visited Turnberry, not by accident, I would say, the day after the Brexit vote to brag, just arrived in Scotland, places going wild over the vote. They're about to take their country back, just like we will in America. No games. What he admitted to remember was that the Scots voted overwhelmingly to remain, and my Scottish colleagues raised the bar in terms of both profanity and creative use of the English language. If you go on Twitter, I won't read them all, but certainly they were not particularly impressed by that. But it is instructive to look at what happened with Brexit. It was a vote about the future, and yet the people who overwhelmingly voted for it were old people. They're not going to be in the future very much longer. And yet the vote was, amongst young people, was disproportionately towards Remain. And what we saw in the Brexit vote was essentially the places with the most elderly people, with the fewest college graduates, with the people identifying most as English, a sort of nationalism measure, were the areas that went towards Brexit. And there may be a metaphor, and Mr. Trump has said Brexit times 5, and we'll find out by the end of the day. As I mentioned, I've had this partnership with the Harris Poll in Harvard for a long time, and my colleague Bob Blendon, who's got this great new project he's doing with Politico, did a survey just a few weeks ago, which really, I think, captures the differences and the deep divide in the country with regard to how the electorate think about the Affordable Care Act. Trump voters disproportionately think it's going very poorly. Clinton supporters are on the other side of that argument. And it turns out, according to Bob's analysis, that the fundamental dividing line is attitudes towards the role of government. So if you believe that government should play a bigger role, you think the Affordable Care Act's doing okay. If you believe that the government should play less of a role, you think it's doing horribly. And so that is, it's not really you've made some systematic judgment based on evidence. It's much more about the attitudes towards government and the role of government in healthcare. And that spills over into what should happen to the Affordable Care Act. People who are supporting Trump generally want to repeal it or scale it back. People supporting Clinton want to build on it or go even further. So those are the divides in the country. And as Bob taught us all, those of us who had the opportunity to work with them over the years, the only time you see major changes in health policy is when you get one team running the table. And the question is that going to happen this time around? And let's just play the extremes. If Democrats were to win and win the Senate, unlikely they'd win the House, you'd probably see an expansion in subsidies to shore up some of the affordability issues. You'd probably see subsidies to shore up the high deductible health plan issue, which we'll get into in a little bit in a second. Perhaps expansion for groups who are previously not covered, more funds for prevention, and certainly attitudes nationally favor action on pharmaceutical pricing. The Cadillac tax, in our view, the group I work with, basically is not ever coming back, no matter who's running the country. And there might be a lot of talk about public options and single payer, but they wouldn't actually do anything. The real question, and I think the question for the country that will be decided by this election, maybe more states will expand Medicaid, and we'll hear from our good colleagues in a second as to whether that's real or not. If Republicans were to win and run the table, I think they're going to get rid of Obamacare. They're certainly going to change the name. I can't imagine Trump's going to talk. It's not going to be hugely popular to call it Obamacare with Trump in the White House. But anyway, you know, and it's you know, it's hard to know what they would do really. If you want to go on my website, I did some fake interviews with Donald Trump that I found amusing. But anyway. But again, I think the mandates would be gone. There would be, you know, it would be shifted to the state level. We're going to get rid of the lines, and it's going to be beautiful, beautiful, beautiful. So I'm confident in that. The real question is, are rich people going to keep writing a check for poor people? Are we going to see coverage continue and subsidies exist going forward? And the best analysis I've seen by various reputable sources, if Hillary wins and we have Team A in the White House, coverage might be expanded by a further 9 million. If Team B wins, we may lose 20 million uninsured. And that would be sad because I think we've made significant progress. Like it or not, Obamacare has reduced the uninsured across the country. I spent a lot of my time in boardrooms with large provider systems, and you can see it depending on which state you go to, the impact this has had across the country. It's been achieved through both exchanges, which have had a rocky time in this I guess we're in our third year now, but mostly through Medicaid expansion, and that is the big story. Very few hospital CEOs will say, I've seen a huge number of exchange people coming through. Not so much in Florida, because it is a big deal in Florida and Texas. What they really have seen is an expansion of Medicaid. The other thing we've seen, and you've heard from the officials at CMS and other experts, is this massive move towards payment reform, which I think is irreversible and will continue under any political scenario, partly because it's being reinforced by the behavior of people on the ground. Because the people I work with, the large integrated delivery systems, are quite committed to a move away from unfettered fee-for-service. I mean, I think, let me give you two signal conditions. The fact that Dan Walterman, who runs Memorial Hermann, is retiring and was replaced by Ben Chu, who ran Kaiser in Southern California. Similarly, Joel Allison, the great CEO of Baylor Scott & White, is retiring, and they have recruited Jim Hinton, who ran Presbyterian in Albuquerque, one of the large integrated systems in the country. That is a signal to me that the boards of these major institutions see a future very different from the past. The other thing we're seeing is this massive consolidation going on across the country. I'll say a little bit more about that, both at the plan level, but more importantly at the provider level. And we sometimes forget that there is this enormous long-term secular shift away from inpatient to the ambulatory environment. And this is very profound. My wife had knee surgery a couple of weeks ago. I dropped her off at 7 in the morning. Well, I didn't just drop her off. I waited till she was out of the OR. But I had to go to another meeting, and a friend picked her up. She was back home by 11 o'clock. Now, if you had knee surgery in Scotland when I was a kid, you'd be in hospital for 6 weeks. So the world has changed significantly. And the other big change we sometimes miss that was really generated by the Affordable Care, not by the Affordable Care Act, by the stimulus bill and the High Tech Act, was the ubiquitous deployment of electronic health records. We've at least got into the 20th century, if not the 21st century. The work that needs to be done, in my view, is enhancing the consumer and provider experience in healthcare. And what we've seen as a mega trend, particularly in the employer-sponsored insurance market, is the shift towards high deductible care, which is a very blunt instrument, in my view, and has not been particularly effective. It's been effective in containing employers' costs, but it's not necessarily been the best thing for the people paying who are receiving care. And the other point to note is that we in healthcare, we don't exist in a vacuum. I live in Menlo Park, California, ground zero of Google and Facebook and venture capital, and a massive amount of money has been put into consumer-facing apps, and it's partly because we in healthcare, think about how you run your own life. Everything you consume or interact with your family or reservations for travel or restaurants is done through your phone. And yet when you have to deal with healthcare, you have to step back into another century, deal with people who are writing things on whiteboards in Babylonic cuneiform, writing things on Post-it notes and faxing things to each other. I mean, the fax machine should have been out of business 25 years ago, and yet it is the lifeblood of American healthcare. So this is just the slide you have to show in some states to prove that Obamacare actually did work in terms of reducing the uninsured, the biggest reduction in the uninsured since LBJ. And of course, I need not tell this group that the uninsured reduction was more significant in states that expanded Medicaid than states that did not. And that, I think, is the important backdrop on this election day. So, from my perspective, here are the stories I'm seeing and hearing in my travels across the country. Some of this is just based on what I'm hearing, but also this partnership I have with Harris and Harvard we survey every year doctors, consumers, employers, and hospital leaders. And I'm going to give you a sort of greatest hits of all of those and spend a little bit of time in particular on shallow-pocketed consumers. The reason why I think it's different this time and all this health policy stuff is a pretty simple fact. The average American family cannot afford the average health insurance premium. Now, you think about that for 8 nanoseconds, that's a wee bit of a problem, right? The average French family can afford the average premium because it costs half as much. So median household income this year in America will be $56,000. Median PPO policy for a family of 4 in the employer market is $18,142. Does not compute. And moreover, what we've done over the last few years is seen this cumulative increase in unaffordability of premiums. And the top 2 lines, the green line is workers' contribution to premiums, compared to the blue line at the top, which is health insurance premiums. Generally, the green line being above the blue line means that there's been cost shift to the employees. The bottom 2 lines are overall workers' earnings and inflation, and of course, they are way, way, way less than the increase in premiums. And again, the average family, therefore, hasn't had a wage increase. Any increment in compensation came in the form of health benefits. And this is the point we're at now, where, according to Kaiser Family Foundation, we're up around 18,142, including what both employers and workers pay. That does not include out-of-pocket costs. If you use the Millman numbers with out-of-pocket costs, you're up around 25 grand. So what's corporate America's big idea? Their big idea is to shift costs to consumers. And we're at the point now where 50% of workers who have health insurance have a deductible of $1,000 or more, 29% of a deductible of $2,000 or more, 20% of a deductible of $3,000 or more. Why is that significant? Median households don't have $3,000, right? They don't have that in financial assets. And that's why what we've seen is that they forego care. And this is not our data, this is data from the Commonwealth Fund. If you look on the right-hand side of the chart, this is people who have jobs, who have health insurance, who are doing it right. They just happen, in the case of the dark blue line, to make less than 200% of the federal poverty level. And if you're in that category, about half of folk in that category have foregone care of one type or another, either had a problem but didn't go to a clinic, didn't fill a prescription, skipped a test or treatment, didn't see a specialist. And it would be lovely and convenient for economists and a beautiful thing if they were only foregoing unnecessary care, but that is not what happens. I mean, when I was on the board of CHCF, we gave the RAND organization, I don't know, $3 million to prove the obvious, which is when people have to pay out of pocket, they don't get stuff, and some of that matters to their health. Now, let me just say, when it comes to consumers, I hate satisfaction surveys. Just hate them. Why? Because they don't move, right? We waste acres of real estate doing these satisfaction surveys, and they don't move over time. Why is that? Americans are nice people. You know, you want to see dissatisfaction? Go survey the French. Right? They're pissed off about everything. Now, the reason we do it is occasionally you see a movement, and we did see a significant drop in the last couple of years in the percent of Americans who say the insurance plan meets my family's needs very or extremely well. And that was particularly acute for exchange folk. By the way, I would point out that people on Medicaid are as happy as people on commercial plans with this. They are much more positive than people on exchanges. And in fact, when we look, what we like is not satisfaction surveys. We put together this emotional scale that we ask consumers about. And the question is, how would you describe your feelings about the health care you receive today, including how much you pay for it and the benefits you receive? Please select all that apply. Now, this is going to come as a complete shock to the men in the room. You can have more than one emotion simultaneously. Women understand that. Men have a great deal of difficulty with that concept. They have trouble coming up with one emotion at a time, let alone more than one emotion. But you see what you'd expect as a social scientist. You see a normal distribution around the stuff in the middle, accepting, neutral, resigned. You don't see many people saying empowered. And a lot, surprising numbers of people say they're powerless, depressed, and angry. Now, I put the California numbers in just to brag a bit as a Californian, and I think the reason why the numbers skew more positively in California is we have Kaiser, we have HMOs, which are generally high deductible, not high deductible, and we have a much higher penetration than most other parts of the country. And we have Medicaid that's huge. A third of Californians are on Medicaid. All of those reduce the out-of-pocket cost burden, which I think tracks to satisfaction. And we know when we break this out in our survey by class of insurance, it's actually ironic that the people who are skew more positively have public insurance, not private insurance. In fact, fewer people with commercial insurance, employer-sponsored coverage, are hopeful, and as many are powerless, the orange on the left. And the numbers for public insurance, rather, tend to be slightly better on the positive side and less negative on the negative side, which is, maybe a function of expectations. So one of the things we know from consumers, we have a very big sample in this survey. One thing we know about consumers that is sort of interesting is the role that out-of-pocket cost plays. 28% of Americans have received a balanced bill for care they thought was covered. If you're in that category, you're much more likely to say you're powerless, depressed, and angry. Similarly, about 8% of Americans received a bill for hospital services not in network, even though the hospital was in network. The ultimate example of this was a woman in Southern California who went to see her physician. He said, oh yeah, I can take care of that problem. Just go, and she made sure she had a PPO policy, she wanted choice, she made absolutely sure the doctor was in network. Had this problem, the doctor said, oh, I can take care of that. Just go to my surgery center on the second floor, one floor up from my office, where he suddenly was out of network and sent her a bill for $18,000, right? Didn't resolve the problem clinically. She had to go to a hospital. This time she's really making sure that the surgeon's in network and the hospital's in network, only to find that the anesthesiologist and the second assistant surgeon were out of network. They sent her collective bills for $24,000, all perfectly legal, right? This has caused some states like New York to pass the No Surprises Law, which tells you you have to inform the patient in advance they're going to be screwed by the second assistant surgeon. I'm sorry, transparency is not a solution here. That's wrong, in my view, that these hospitals are conspiring to defraud patients in a gotcha. So the other thing we found in our survey with regard to this out-of-pocket cost stuff, we found a group of patients, about 10% of the American public, who use the health system a lot and have trouble paying for it. Another word for them would be patience. Because almost anyone who's admitted to a hospital or has a serious procedure done and makes less than 150 grand a year is going to be in this category. And again, they're not all on Medicaid. In fact, fewer than average are on Medicaid. They are disproportionately uninsured to be true, but most of them have employer-sponsored coverage. And what we see here is that if you're in that category, you skew very heavily to the negative end of the spectrum of powerless, depressed, and angry. So what do consumers want? Well, in a word, they want cheaper, right? We put them through a trade-off exercise. I won't bore you with the details, but basically, you can have this or you can have that. You can't have both. Which do you prefer? You do that over a big enough sample, and you reveal relative preferences. And what they basically tell us is, give me low premiums, low deductibles, low copays, and I'll trade off choice for cost, right? That's basically what the story is. And one of the things we found in this rare and horribly partisan election cycle is that the one thing that seems to have bipartisan support amongst the people who vote Republican, Democrat, or Independent is reducing out-of-pocket costs. And that, I think, is going to be a focus, certainly if Hillary Clinton is elected president. So let me say a few things. I'm not going to go into as much depth in the other stories, but I want to just hit on a few of the trends that we think are important for the market to watch and have some implication for all of you in your roles. The first has to do with consolidation. And we are seeing this both at the health plan level, although I think one or two of these mergers might not be consummated because of resistance from the Department of Justice. I was talking to a liberal group of doctors at UCSF a couple of months ago, and I said, the good news for you liberals is we're going to have a single payer system. The bad news is it's United Healthcare. So I'm not really that worried about, I got the DOJ lawyers called me. I said, I don't have a problem with it. As long as there's 3 of them, it's fine. What I'm much more concerned about is what I see in every market I go to. And I do a lot of board retreats with a lot of hospital systems across the country. And what we're seeing here is the creation of 200 large regional integrated delivery systems across the country that are coming to dominate the landscape. Now, when I say dominate, it doesn't mean everybody is going to work for them, but certainly we're seeing doctors running to hospitals to huddle for warmth. We're seeing hospitals consolidating regionally. We're seeing the role of for-profit and private equity money driving some of this. The bond market thinks it's a good idea. And there is a positive upside from this integration, which is if you think about a managerial success where you drive out inappropriate clinical variation, you improve quality and reduce cost, that would be a win for the world. It would be a win for the health system. Unfortunately, the data don't support that. The tendency is to use pricing power to raise prices rather than yield true efficiencies. And by the way, this isn't going over well with the people who pay the bill. And I don't just mean Medicare and Medicaid. The people who are the lifeblood, financial lifeblood of the American healthcare delivery system are private employers. Now, I'm an advisor to the Pacific Business Group on Health, which is a coalition of large employers. Pacific is a kind of a misnomer because it includes Walmart and Disney and GE and so forth. And their view of the world is not the Donald Trump 1726, 653% increase view. Their view is 4%. 2016, 4% increase. And the good news about employers is that they're not leaving. They're not abandoning the field. It's been surprising positive effect to the Affordable Care Act that the number of people with commercial health insurance has remained relatively flat, as CBO had predicted. What we track in our polls is the red line, which is the percent of American employers who say my company is actively exploring ways to get out of providing health insurance to our employees. And you can see that red line. You don't have to read the numbers. It just went up and it came down. And the reason is that they took a look at private exchanges. They took a look at exiting the field and made a determination that there was really fundamentally their responsibility to ensure their health, their employees' needs were met. That's the 87, 88% number at the top. So they're not leaving. That's the good news is. The bad news for the delivery system is they're not leaving, right? And they're going to be in the face of the delivery system going forward. And that's what we've seen. We hear anecdotally this year, employers putting pressure on their health plans to get zero premium increases or zero price increases from these provider systems. But there is a mega trend that is still troubling, and I don't think Obama should be blamed for this. This is the progressive unaffordability of healthcare, which reflects this, is that over time, we're seeing fewer and fewer workers covered by employee health benefits. And the reason that is true is because of the progressive unaffordability of healthcare. Look, I live in Silicon Valley. A lot of people work at Google. Not a lot of people work for Google. The people cleaning the floors are contractors, and they generally have less health benefits than the really sophisticated, high-tech folk. The other trend that relates to this is employers' experience of price. Now, this is a sophisticated audience. You all know about the Dartmouth Atlas, which is the left-hand side view in this chart, where Medicare spending per capita has been rigorously kind of analyzed by the folks at Dartmouth, and the dark areas of the country are expensive and the light areas are cheap. What you don't always see is the chart on the right-hand side, which is the smart Alex at Harvard who actually did the same analysis, only with self-insured employers' data. And this explains the mystery for those of us who travel around the country. You get states like Wisconsin where hospitals are getting 300% of Medicare, in the private sector. There is huge variation across the country in the rates paid. Even in my state, California, Northern California has low utilization and very high prices. Southern California, it's the other way around. That's why even in Kaiser, there's $100 per member per month difference between Northern and Southern California rates. And this is the hardest data in America to get, so I just made it up. And it's a little hard to, the labels got squished, but let me talk you through it. On the left-hand side, if you do coronary bypass surgery on an uninsured human in Oklahoma and you send them a bill and sick a collections agency on them, you'll get 7 cents back on the dollar. Medicaid in my state pays 69% of costs on the inpatient basis. Medicare pays 89% of costs. So you don't have to be a rocket scientist or a futurist to figure out you got to charge the private sector more if you're a provider. And on average, it's around 150% of cost. The dream is to get the number on the right-hand side, which I call the demented Saudi prince price, which is what would a Saudi prince pay at Johns Hopkins? And that's what hospital CFOs call the charge master. But again, it's tough to see the labels here. But what we did with exchanges is inserted another player in the mix. So every hospital board I do, this is the story you hear. We had windfall, this is in an expansion state. We have windfall profits on the inpatient side because our bad debt went way down. In Oregon, it went from 6% of total revenue to 4% for hospitals, like that. And it's true in many, many states across the country. The problem is you've now permanently impaired your payer mix because you've got way more Medicaid patients. And that's why over time, we're going to see the slow deterioration of the finances of those hospitals, many of whom were doing spectacularly well in 2015. And I didn't really just make the data up. The American Hospital Association actually tracks this stuff. And we're seeing a widening gap between what Medicare and Medicaid pays relative to cost and what private payers pay. Now, there's a little bit of whining going on here. When these CFOs say to me, well, Medicare doesn't pay the true cost of care, I say, let's rephrase that. Medicare doesn't pay for the income aspirations for you and your people doing things exactly the same way, right? Which doesn't sound quite so good. But that's kind of what's going on. Now, I know this is going to be painful. All of you in this room are feeling this sting. This is, at the PBGH board meeting, this is the #1 issue for employers. I was with the CEO of Care First in Maryland a couple of weeks ago on a panel. He said, and Maryland's an odd state because it's an all-payer rate-setting state, but he said for the first time in the commercial market, specialty pharma per member per month now exceeds inpatient hospital spend. Pharma per member per month exceeds inpatient hospital spend for all carriers that I've talked to in the commercial market. And it's going up dramatically because the entire pharmaceutical industry, including the old legacy players, are pivoting to large molecule biological entities with very high prices. And it's gotten kind of ridiculous. Hep C being the prime example. Hep C costs 84 grand treatment in the US, 900 in Egypt. So I put together this slide really as a joke, but as we say in Glasgow, half joking, full serious. It's cheaper for a self-insured employer with a Hep C patient to send that patient for a 3-month luxury vacation to Egypt, put them up at the Nile Ritz-Carlton, which is supposed to be spectacular, by the way, give them a meal allowance, have them take their friend or partner, fly them business class, and then tack on the Nile Spa cruise where you'll be pampered to death for 10 days, and you'd still save 30 grand, right? That's nuts. And that's why when we do surveys, 72% of Americans, including a majority of Republicans, believe that price controls or caps on pharmaceuticals should be enacted. So I think we're going to see action on this one way or the other, and it's actually maybe the platform of the Trump administration too. The other thing we're seeing across the country is this migration to try and make volume to value real. And the best estimate I can give you of how real this is from our survey of hospitals, where we ask them, you have to pick one of these options. On the left-hand side is the least invasive, which is we have no plans to take risks beyond modest shared savings and pay for performance arrangements, about a third of hospitals. On the far right-hand side are hospitals who say we are committed to moving the majority of revenues to fully at risk within 5 years. That's around 6 to 8%. And the next to last is building an ACO model that is capable of taking risk, such as Medicare Advantage or employer direct contracting. And I think that's about right. I mean, we ask it another way. About 20% of health systems say that they're going to have an insurance license within 5 years. So I think this is a separation that's going on between the people who want no part of this, people in the middle who are sort of playing at it by doing a clinical integration strategy, and people who are serious about migrating more towards risk over time. And the other thing that's reinforcing this is payment reforms from CMS and private payers, including both bundles and the shift towards population health. And I want to make a distinction between bundles and population health for a second. A bundle, more is still better. It's not so alien to these providers because they're used to being in the growth business. And it does encourage improvement across by putting an envelope further out around the continuum of care. But not everything is easily bundled. And I worry a lot that the sum of the bundles is going to be more than the current payment. And the reason I say that is my good friend Pat Fry, who ran Sutter for many years, who has a tendency for profanity, which I appreciate, said to me about bundles, screw me on the bundle, I'll screw you on the rest. In other words, you can grind me down on orthopedics, but I'm going to charge you more for stuff you can't bundle and come out the same in terms of revenue. And I think that's right. I think that's the way providers play the game. So I'm a big fan of capitation. I'm a big fan of risk. I'm a big fan of accountable care. I'm a big fan of population health because it makes you think about the frequency with which you do things and the appropriateness of it. And it also will cause you to go up the food chain to focus on the determinants of health. And you'll find that a lot of the solutions, and I'm preaching to the converted here because this is where you've been for all your careers, looks a lot more like social work than medical care. And that epiphany is happening all over America with provider systems who are getting into the risk business. But there is this what I call mutual disrespect problem. Everybody in American healthcare thinks everybody else's job is easy and anyone can do what an insurance company does. And that's just not true. So what happens when you get in the risk business? Well, what happens is you hire Optum or other smart aleck consultants and they'll run the numbers and you'll find what is a law of physics that in any insurance pool, 5% of patients account for 50% of costs. 1% of patients account for 20% of costs, and the bottom 50% utilizers use next to nothing, right? Now, what's in that 5%? Well, what's typically in that 5% are Hondas as one key category. What's a Honda? Well, I'm a Honda. I was denied coverage before Obamacare saved my bacon back in 2012 in the individual market in California. I was denied coverage not once, not twice, but thrice. It was thrice denied, positively biblical. And the reason Blue Shield denied me is they said, you're a Honda, hypertensive, obese, non-compliant, diabetic, alcoholic, right? None of which is true, but is kind of directionally correct. Anyway, so the other thing you'll find is behavioral health. 20% of Americans have a behavioral health problem. If you look at super utilizers, it's more like 85%. Anyone who's in end-of-life care will, in the Medicare population, will be in that 5%. Anyone with cancer, active cancer treatment will be in it. The frail elderly and the elderly population. And as I say, social work, not medical care, may be the solution. And by the way, for any clinicians here, in the commercial market, if you prescribe one biological, you'll automatically be in the top 5% high-cost cases in the commercial market. So let me just close by telling a couple of stories and make a couple of observations about what this means for Medicaid. So the stories basically are what I'm hearing how these provider systems are responding to this new future. The story of the truck is this young hospitalist who, a Latino kid who went to UCSF and did well came back, wanted to serve his community in Phoenix.